guys doing? How's lunch? Yeah, all right. Well, I love seeing such a nice turnout on this rainy day. Thank you for coming out to Lunch and Learn, sponsored by WJCT and Baptist Health. I'm Melissa Ross. I host a program every morning on 89.9 FM called First Coast Connect. We host doctors like the physician you're about to hear every Friday on a segment called Weekend Warriors, where we learn about all sorts of topics that can affect people that might hurt themselves on the weekends doing sports or gardening. So this is content you can hear every week on 89.9 FM. We hope you'll tune in for that. And that is sponsored by the Jacksonville Orthopedic Institute. A couple of housekeeping things. We ask that you turn off your cell phones while the doctor gives his talk. And looking on your tables, we've got some nice bumper stickers for all of you. If you heart WJCT, let everybody know it. Slap that right on your car or automobile or vehicle. And then we've got a really nice event coming up this summer. If you see the Save the Date cards there for Speaking of Women's Health, that's a big annual event, and I really encourage you to try to put that on your calendar and come out and take part. Lots of opportunities for women, health screenings, great seminars, fun stuff. It's a really nice event, so save the date. All right, and now let's introduce our speaker. Baptist Health and WJCT are so pleased to present Dr. R. Stephen Lucy, an orthopedic surgeon practicing at JOI San Marco. He's a founding member of the Jacksonville Orthopedic Institute. That's an affiliate of Baptist Health. He's the chairman, and he is also a graduate of the University of North Carolina and the Medical College of Georgia, completing his residency in Colorado. He's board certified in orthopedic surgery, one of only a few in Northeast Florida, who has subspecialty board certification in orthopedic sports medicine. And when I interview these doctors on the topic, it's interesting. There are a lot of ramifications to what he does. Dr. Lucy is the vice chairman of the Department of Orthopedic Surgery at Baptist Medical Center downtown. He's out in the field working with young athletes as head team physician for JU and Bowles. And he's the orthopedic team physician at UNF, so he's really involved in our high school and college sports programs. He is the former team head physician for the Jacksonville Jaguars, so he's worked with the pros too. A founding member of Jacksonville's sports medicine program, past chairman of the Florida Orthopedic Society Sports Medicine Committee, and past president of the Duval County Medical Society. What a distinguished physician we have here today. So please join me now in welcoming Dr. Lucy.
Thank you, Melissa. Thank you. Thank you. Can you hear me? Yeah. Great. Well, it's a pleasure to be here, and I guess we needed the rain's what they always say when we get rain, but hopefully it won't be too bad on your way home, and we appreciate everybody coming out here. And we have some exciting things to tell you about today, some new things that we're doing for knees and for people with arthritis. So hopefully you're here just as an interested person and aren't really here because you need something like this. But we will go through this today and tell you about some new options we have for knees and some of the exciting things that we have for the future. What is arthritis? Well, osteoarthritis is sort of a wear and tear arthritis. If all of us live long enough, we're going to get it. It says 46% of the people will develop it over their lifetime. The ones that don't probably just died of a heart attack before they got it, because if you live long enough, I think you're going to get it. Now, there are some other forms of arthritis that are a little bit more unusual: rheumatoid arthritis, inflammatory arthritis. Some of the things we're talking about today apply to those as well. But most of what we're talking about is just plain old wear and tear. Now, if you weigh about 90 pounds and you've kept in good shape and ate well, chances are you won't be getting this until you're 85 or 90. But if you're one of these 250-pound football players that have abused their knees, ladies that played a lot of tennis, you might wear out a little sooner than that 95-pound lady that's taking perfect care of herself. we see a progression of this from the early stages, and a lot of this of people who have injured, maybe torn a cartilage or had some high school injury. They'll start developing this a little sooner. We call that more post-traumatic arthritis, that is, you got hurt and then developed arthritis. But a lot of us, sometimes with the milder stages, may not even hurt, or it's something that a little Advil or Aleve will get you on your way and you don't have to worry about. As the disease progresses, and it tends to progress over time, if you're a little knock-kneed or a little bow-legged, that's going to make it progress more. If you weigh a few pounds too much, that will progress it a little bit more. To where the really severe knee pain is where it's hard to go shopping, it's hard to go out to get the mail. Stooping down's a problem, and stairs you look at a couple of times before you decide to take it on. Well, what can we do for this? Well, we'll be talking about some surgical treatments, but we certainly try to do some other things for people. Easier said than done, and I notice the Baptist people are trying to make you eat healthy today for lunch, is weight loss. And I had one of the fellows that works with me a bit, I had scheduled for a total knee, and he lost 35 pounds and canceled it and said he didn't feel like he needed it anymore. Now that's unusual, but weight loss can really help this. Non-steroidal anti-inflammatory disease, the prototype of that's been around forever. Aspirin, over-the-counter, the ibuprofen, Advil, Aleve, those type of medicines are things that you can get. The dosage over-the-counter typically aren't quite enough. Most folks can take 2 Aleve twice a day and 3 Advil 3 times a day. That's the prescription strength of those. Or your doctor may prescribe another one of the anti-inflammatories. You have to be careful with all of these. They can eat on your stomach. They can cause problem with your kidneys and livers. And they're better taken intermittently. You have a bad day, take some, but sometimes when your knees or hips or whatever is bothering you is killing you, you really need to take it every day. Sometimes, particularly things like shoulder arthritis, some physical therapy, sometimes early in the stages of hip disease, physical therapy can help that. For our weekend warriors, it's hard to get them to slow down, but all of us will reach a time where running's probably not the best thing on your knees, and probably that morning walk needs to be shortened down a little bit, because we really don't think that those kinds of exercises cause arthritis, but if you have arthritis, doing those kinds of things will definitely make them worse. So we try everything first. If that doesn't work, there are some surgeries that we can do. Melissa was kind enough to introduce me, and I do a lot of sports medicine, kind of as my patients are getting older and I'm getting older, they need more total joints and I'm doing more total joints. So sometimes in the early stages we can get by with an arthroscopy as a small little microscopic type surgery to smooth out things, clean out torn cartilage. In the process of doing that, what a chondroplasty is, where we have little devices that smooth out some of the rough cartilages. These are outpatient procedures. They take about 45 minutes. You can usually be up walking on them within a week. That's a far cry from any type of a joint replacement. So sometimes that's in the early stages in the weekend warrior kind of patients. Usually that's not going to be the best bet for somebody that's 80 years old, although I did an 86-year-old lady last year. She had just a little meniscus tear. I took out her sutures, hadn't seen her since. Her knee probably looked better than mine. So it's not all about the number, how old you are, it's how worn out you are as to what we have to do. Some of these other things on here are fancy doctor terms. Let me see if I can get that back. Microfracture and abrasion. These are some things we try to do to fill in holes in bone and raw spots on bone. Again, this is a little more in the younger patients. It doesn't work so hot for arthritis. And then a tibial osteotomy is another thing that we do, and I'll show you that a little later. We're going to be talking some about partial knee replacements. And as you start wearing out, let's say you're bow-legged, you probably are going to wear out on the inside just the way your tires wear out if they're out of alignment. What a partial knee replacement does is enables us to replace the part that's worn out. Now, total knee replacement replaces all three compartments. We're doing those with what we call minimum incision. They're not as big a deal as they used to be. We've got folks getting up and walking to physical therapy the next day. We've gone from 80% of people going to rehab hospitals and old folks' homes now to 80% of them going home in 3 days. So a lot of our rehab techniques and the programs that we've instituted over at Baptist has made even a total knee not necessarily the end of the world. These total knees really are considered the gold standard. They've been around for 35 years. They have long-term survivorship, so we now know if you've done something for 30 years, you kind of know how long they last. The ones we were doing 15 years ago, some of them are starting to wear out, but what we've learned now is what tends to wear out is the plastic in them. And if we catch them and follow them along, people start clicking or clacking or swelling or having some pain, and if we catch them at that point, it's a fairly simple procedure to go in and change the plastic, so they might get another 10 or 15 years. So it's conceivable that even the knees we were doing 15 years ago, we can get 30 years as long as we are able to follow people with that. So it's more like changing a tire at that 15 year than buying a whole new car. And it is a very successful procedure. Everybody probably knows somebody that's had a total knee. If the person that you know that's had one didn't have such a hot result, you're going to be worried about it. But nationally, 9 out of 10 people are pretty satisfied with their total knee. And that's not saying that a total knee is as good as your knee when you were 30, because it's not. But what a total knee is supposed to be better of is your knee when it's old and worn out. And it does do a pretty good job of that. The total knee is a little more invasive. It does require a little more rehabilitation. Sometimes I've found myself replacing parts of the knees that look pretty good. And this happens all the time. And this particularly has been happening with the advertising surrounding this Mako and partial knee replacement. They studied this up at Duke, and almost 90% of the people that came to the doctor, and I saw one today, when they come in and they go, my knee hurts, and you take an x-ray and the knee's worn out, and you go, you know, we can do this and that, but you really need a total knee. And that isn't what they came for. They wanted a magic pill, the magic wand, whatever. And a lot of them, when you say, I think you do better with a total knee, they go, well, Doc, thanks a lot. Let me go home and think about that, and I'll get back in touch with you. And we've seen that with some of the advertising with this Mako deal, is that people come in and go, I want one of those, and we'll take an x-ray, and you know, you kind of, about 10 years ago, maybe you could have gotten one of those, but now you don't need one. You need a whole joint replacement, and they'll do the same thing. Doc, that was nice meeting you, but let me go home and think about that. So I'm not real sure about that. So our experience is not quite 90%, but we do see a lot of folks that don't want to hear it. And what we're doing today is trying to give you guys some education on what this all means, because some people think that when we do a total knee, we're going to cut out about that much of your knee and put some hinge thing in there. And if we put it in sideways, you're going to walk backwards. And it's really not quite that big a deal. This partial knee surgery, it really only is targeting the worn out part of the joint. And it is less invasive. I had a fellow, one of the first ones I did, came back in the office in 3 weeks and wanted to go play golf. I wouldn't let him, but that's how good he felt. The robotic part of this we'll get into, but what that enables us to do is to put these things in perfect position, which in turn, the better position these things are, the less stress there's going to be on them and the longer they're going to last. Partial knee replacements, as this slide shows, there are almost 600,000 total knees done in the country. And as all of us baby boomers get older, that number is growing. It's a huge segment. But of that 600,000, 50 are only about 1 in 10 are partial replacements. So you can see that most people are still getting total knees. It's a still good operation. But now that we have some options, I think that number of partial is probably going to increase. Well, what is this Makoplasty, a robotic-assisted partial knee? Well, it's a minimally invasive procedure, meaning we can do it through incision about that big rather than from one about that big. The robot doesn't do the surgery. We do the surgery, but the robot, if you think about a gadget that if you look at your plate, this robot, once it's programmed in, will not allow me to put it in the wrong position. I hit a virtual wall. If you said it needs to be this deep, it goes to that depth and it stops. You don't see where you can't. You don't see where the walls are, but you can see where the walls are on the computer screen, and it actually stops you and it makes you put it in exactly the programmed position. So that's a huge advantage because the total knees are a little more forgiving. These partial knees, if we put them in angle just a few degrees off, it will make them wear out or get loose sooner. So this shows the most common thing we do because we got a whole lot more bow-legged people than knock-knee people, but this shows the inside to where the rest of this is normal knee. This is a metal piece, this is metal backing, but that's just a serving tray to hold the plastic. And you'll see as we go along, all total joints, typically, we're having a piece of metal go against a fancy piece of plastic. This shows a replacement. It doesn't show the kneecap, but this is a patella replacement. A few people wear out under their kneecaps, and this is a way that we replace this, and we replace under the kneecap. And then this is for some of the knock-knee people. This is a little less frequently done. This is the outside replacement. And what we're now able to do in someone who has worn out the inside plus the kneecap is we can combine these two, which is something fairly new. This partial knee replacement has been around at least 20 years. But the robotic part of this, they've been working on probably for about 5 years. I first looked at it about 3 years ago, and it looked like a good gadget. They didn't have all their implants sorted out. But within the past couple of years, they have come up with a very nice implant to go along with the robotic technology to where it's definitely an advance. This is the robot. It's a fancy arm which holds a burr, and we'll show that a little later. This is a navigation device. You put some optical instruments on the patient. This reads it, and it creates a virtual knee on the computer screen that you'll be able to see. And then the guys over here that I'm showing are the guys that run the computer, and they then can change exactly the positions and roll this in one direction or another, in or out, until they get the perfect balance of the knee, which is also something that we never had before. When we do, we have to know how to balance things, but we've never had measuring instruments to say, this is too tight, this is too loose. This enables us to put this within a millimeter or so. Now, it does require a little time because what we're doing to create this is many of you in the room have probably had an MRI or a CT scan at some point. But this procedure, we do a CAT scan and then send it to the Mako people, and they will create a virtual image of your knee based on that scan. So then they will create, it has all the bumps, the bone spurs, the crookedness, the wear, whatever, of your knee. And then they can then take that and plan the size you need, the degree of correction you need based on that. So then in surgery, we come down and we register that same knee with the optical instruments, and then it matches whether that day in surgery these two things match. And then you match the robot to this and register all that, and then therefore this robot is programmed for your knee, not Susie's knee I did yesterday. It is strictly for exactly your knee based on that CT scan, and then double checked by the images that are done in the time of the surgery. So the potential advantages here is it's definitely less invasive. There's a smaller incision. We're only really removing the portion of the knee that's arthritic. And more importantly, the joint is optimally positioned because, we don't, sometimes doing partial joint replacements in the past, we've told people that, these partials definitely feel more normal. But in the past, we weren't really sure they were going to last longer. We're getting more and more encouraged that they will last longer. So it became a decision, do you want to do something that might only last 10 years, but it'll be 10 better years, or do you want something that's a little more invasive that might last longer? With this, if we choose a patient, these should last about the same length of time as a total knee. So what we're seeing already is improving outcomes. My patient that wanted to go play golf is an example of that. We're really not removing as much bone, so if sometime down the line, if you only had one side of your knee worn out and in another 10 years the other side of the knee wears out, we can still do a traditional total knee. Our blood loss is reduced because of the nature of the surgery. These people eventually, I think, may get to an outpatient surgery, but right now we've cut it to about 2 days. I know down in Naples, one of the companies put in an outpatient total joint center. I think that's fairly optimistic for now because a lot of it is patient expectation. If you come in expecting that you're going to go to a rehab center for 10 days after your surgery, a lot of times that's what you're going to do. If you come in expecting to go home, then you'll probably go home. So a lot of this is patient expectation, but these people are up walking around, bending their knee. They have a fairly rapid recovery. There's less scarring because there's less surgery. And one of the things, as I mentioned with the total knee, which is still a great operation, total knees don't like to kneel. They don't like to squat very much. They click and clack a little bit. And these feel much more like a normal knee because you retain all the ligaments. And part of the reason the total knees don't like to kneel is because you've removed one of the ligaments that when you kneel, it pushes up against them. And so there's some things that most people don't mind if they've been hurting enough, but if you can have an operation that you could be more normal, certainly that's a big advantage, and we're hopeful that there's going to be less implant wear because of the perfect positioning. So this hadn't been around. I can't tell you that it's going to last 20 years. We don't know. We have a lot of bright ideas that turn out in 10 or 15 years to not be as bright as we thought. But this is reasonably old technology applied better as far as the total joint is concerned. So it's not a newfangled contraption. So who's a good candidate for that? Well, it's hard for you as a patient to know whether you're a good candidate. You know your knee hurts, so I wouldn't expect you to say, well, I need one of these. But typically, if you only hurt on the inside of the knee and it just started hurting and you're bow-legged, you might be a candidate. If you only hurt under your kneecap, chances are therapy might help, but if not, we do see a few people that this is a good candidate for. A little more rare are that people that hurt on the outside of their knee, because most of the people I see on the outside of their knee, they've kind of let it go too far. And we don't see a lot of those, but we do see some. Those of you who have arthritis know this deal. First thing in the morning it's stiff. Once you get going, it lubricates up, or if you sit for a period of time and get going, that's a typical finding of arthritis. And then, you know, we still think that there's plenty of place for non-surgical treatment of all types of arthritis, and we want to try anything we can to avoid surgery, but sometimes you see somebody that comes in and they are a good candidate for this. And if you procrastinate too much early, you will progress from that moderate stage to the more severe stage where you do need the whole replacement. So there is an element of you need to have it checked in the early stages of the disease and trust your doctor not to pull the trigger on the surgery until it's necessary. So who can tell? As I said, it's hard for you guys to tell. Usually you need to be seen by a orthopedic surgeon that's used to doing total joint replacements. There are a lot of orthopedic surgeons and total joint surgeons that don't believe in partial replacements. And you know, I had one of them that was in that camp that helped me with one yesterday, and I think he was very impressed with this. I think that 5 to 10 years ago, our partial replacements didn't last as long, and there's a whole group of surgeons that grew up thinking that it's not worth fooling with. But in the past, I'd say 5 to 7 years, there's been an explosion of new technology, not only by the Mako people, but from other companies, and there's been a renewed interest in partial joint replacement because it is more normal. And you know, we're seeing a lot more people now because there's so many more people that are in their mid to 50s to mid 60s because of this baby boomers. They're still very active people. And you know, some of them, a total joint replacement just isn't quite what they want, and they want to be a little more active. And so that's a product of their times. It does require an x-ray. One of the questions that one of the people sent that came out of one of the last lunch and learns was, do you have to have an MRI or arthroscopy to know if you're a candidate? And the answer is no. If you've had an MRI, it's helpful. If you've had a previous arthroscopy where the doctor has pictures, that's helpful. But a lot of times we can just tell by plain old x-rays. We do not have to do a lot of expensive tests to tell whether you're a candidate. So this is a typical person, and this is their x-ray. And as you look here, this is what we look for. This space between the joints is where your cartilage is. And if you think of that in my tire analogy, this outside tire still's got 40,000 miles on it. This inside tire's got some wear. Now sometimes in the one I did yesterday, the bone was about on the bone. But probably here, there's some bare spots. You know, you don't see it on the x-ray, but if you were to look in there, there'd be some bare spots. But this person mainly just had pain on the inside. This is a side view, not a lot of bone spurs. It all looks pretty good. And so this patient was a good candidate, and this is what one of these Mako partial knees. So we've really only replaced the side that's worn. This side wasn't worn, we didn't mess with it. Under the kneecap wasn't worn, we didn't mess with it. And this, as you see, this is perfectly positioned parallel to the floor. It's not angled, which is surprisingly harder to get it perfect than you'd think. And then this is a metal piece on the top. What you can't see here is the plastic, because on x-rays, plastic doesn't show up on x-ray. This is a side view, and you see again, total knees. We're not chopping bones out up here and putting hinges. You know, we're removing, you know, 1/4 inch, you know, maybe a little more, 3/8 of an inch of bone, and we're applying this to the bone. So it's really like retreading tires. And we've just capping the top, and what's on here is the white is metal. Again, the plastic is clear so you don't see that. Now this is somebody that came in, and you can see they worn on both sides. You know, this person, he might have come in looking for a Mako, but you know, they wore out on both sides, and that, you know, that person has what we call 3-compartment disease, inside, outside, and under the kneecap. So that person got knee replacements. Now this, and you can see from the other side, this is a little bit bigger deal. This whole gizmo here is a fancy serving tray to hold the plastic. But we found that if you make that piece all plastic, it tends to bend and deform a little and can get loose. And then, again, on the side view, though, again, we're not chopping out your leg. We don't have a hinge. Your ligaments are there. The metal is it's a little more than the last one, but it's just recapping the bones. And then there's a little plastic button under the kneecap. So we talked a little about life expectancy. We don't think any of these things are going to last forever. If you're really overweight, 100 pounds overweight, it just makes common sense. If you load up the half-ton pickup with 3/4 tons of stuff, it's going to wear out sooner. This is the same. You know, if you're super active, it's like the little old lady driving a car. Her tires are going to last more than the 18-year-olds. So how vigorous you are, what your bone stock is, how good you do. You know, we don't like people running on any of these things, but we don't mind people going out for walks. We let them play golf. We do bowling. We have some people that play doubles tennis, but we don't like people playing singles tennis. And again, it gets down to how long they last. Is this how well they're aligned? And that's where this computer and this robot enables us to get the best possible alignment. So, you know, I had, with some of this advertising, I knew it was going to happen. It was just a matter of when. This 32-year-old lady comes in, and she wants one. And, you know, we don't like to do total joints in people under 50. Sometimes we will, but, you know, if we put in something on particularly a female that, you know, is 35, how long are they going to live? You know, who knows? You know, they might live 70 years. And so we have some other things that we do that are still good options. And this is sort of a scary thing, but it's really a very good operation. This is an athlete. These screws are from an anterior cruciate ACL reconstruction. You hear the football players. And he was wearing out on the inside, pain on the inside. He brought me pictures of a previous arthroscopy that showed that it was painful. And so, yes, you could do a partial knee replacement on him, but at his age, what we did was change him from being bow-legged. And the way we did that, we took a wedge of bone out of here, and now you can see he's knock-kneed, bow-legged and knock-kneed. And what that does, instead of all that weight going over on this inside, now the weight's going on the side that is good. So we have just transferred where those forces. Any of y'all are teachers, that might be the only part of physics I still use. But, you know, we are excited about this robotic assisted resurfacing. You know, whether you're a candidate, you're going to have to see one of us or see your primary care physician to refer to one of us, and we will be happy to look at you. When we first started this, Channel 4 was nice enough to come by and do a story on this. And we have a video from a story that appeared on Channel 4 that the reporter, and my son's a TV reporter, that did this was in to see me the other day, and she said, you know, Doc, the first time I did this, they made me cut out a lot of stuff because they said, hey, this is a 6 o'clock news, people trying to eat dinner. So here, they're trying to eat lunch. So I think Haley has cut out any of the gory things in it, but it gives you a little idea of what we're doing. So if we could play that video from Channel 4.
Betty Bell says her husband's knee has been killing him ever since they moved here.
We moved from Virginia Beach, we moved here to Fernandina Beach, and we're doing a lot more outside work.
Robert Bell has what's called a collapsed medial compartment and needed partial knee resurfacing. So doctors went in with the help of a robot.
The robot uses a computer to put the total knee in exactly the right position. So I drive the robot, but the robot will not let me put it in the wrong place.
They put Mr. Bell under anesthesia, wrapped his right leg, and made their marks. Dr. Stephen Lucy uses a virtual image of Bell's knee to help him locate where the implant will go in the cartilage. Now that the cartilage mapping is complete and the knee has been prepped, it's time to bring out the robot. As Dr. Lucy shaves the bone, look at the screen. The robot won't allow him to go past the red and shave too deep, allowing for sub-millimeter accuracy. Then Dr. Lucy puts in the new implant, a perfect fit. Doctors say the Rio robot results in a more natural feel, better knee function, and a longer lifespan for the implant.
Many of us wear out because we didn't come from the factory precisely placed. We might be a little bow-legged or a little knock-kneed, and that's what made us wear out. So by putting these implants in a perfect position, we're hopeful that they will last 10, 15, 20 years.
Mr. Bell's surgery was a success. They stitch and staple him back up and wrap up his new knee. His wife can't wait to have him back.
We're such a team, so I miss my wingman. I don't want to be doing solo, and for us to, for him to get out there, back out there, enjoy the walking, enjoying the nature, and getting out there and playing the golf. That's what retirement is for here. We're here just to relax, unwind, and have some good times, and we want to do it painless.
Dr. Lucy says Robert should be walking to therapy tomorrow, thanks to these professionals and the help of their new friend. At Baptist Health, Haley Winslow, the local station.
This is the fellow that came in and wanted to go play golf in 3 weeks. So that's pretty much it. We've left plenty of time for questions. Don't be bashful. We'll try our best to answer any of your questions that you may have concerning this.
What's the malfunction? The malfunction. Does this robotic? Yeah, the arm.
Does it malfunction?
Yeah.
So far it hadn't. But that's a good question. Maybe we could ask our fellows over here, because if it did, we'd be in a world of trouble, but so far it has not. They double check it several times, and every time we switch from one bone to the other, we recheck it to be sure that that robot knows where it is and what it's supposed to be doing. Yes, sir. Yes. Has it malfunctioned?
To date, we can report to the FDA we've done about 15,000 procedures, and we've had 3 where we've had to change the procedure because of the robot. Yep.
Well, I'm not concerned about the robot right now. I have both of mine done. My knees, I have both of them replaced.
Mm-hmm.
And the thing about it is, I went for 12 long years until I got so, I was about bent down to the ground. One knee was hurting, but then I shifted my body to the other side and wore out the other side. And I was much heavier than I am now. But anyway, I'm glad that when they decided to do one, and they said do the other, but I postponed the other because that one hurt pretty bad. So it got all right. So I think it got better than I went and had the other one did. And like you say, now they're doing it so much that I didn't have to come out. I came out the hospital and came home. I didn't have to go to rehab. And as long as you take your exercises, it's very good. And I wouldn't take nothing for them. I can stand straight. It was so many days that I wanted to stand straight, got up and couldn't get up. But I'm thankful for the surgery.
Well, we're glad you did so well, and see, now we have at least one person that did well, and she's and what she's saying is pretty typical. Some people do come in and they go, just fix both of them, and if you do that, and we do it occasionally, but I think it's better to do exactly the way you do it, because you can go home. It's not such a big surgery to yourself. We prefer to do them exactly the way you did it. And a lot of people do, once you get one, that total knee actually becomes your good knee. You start shifting the weight off your bad knee and you can postpone it for a while. And I think the way you did it is the way we prefer to do it.
Question for you, and it is about the height of the shoes that we wear as women. My left knee just kind of bothers me at this point, you know, from time to time, but I go from flats to heels to wedges to whatever, and I'm just wondering, does that have any bearing on my knee wearing it out sooner, or, you know, I know weight loss is of course something that we all have to do to live better, but how does the shoes affect the knee?
Well, you know, in the young ladies that are wearing high heels, I don't think it really does, you know, I don't think it contributes to wear. But once you start getting some wear in your knee, you'll probably find that certain types of shoes work better than others. And it may be that pure flat pump or pure flat flip-flop is worse on your knee than a slight heel. So once you start wearing, you may find what the best way to put your foot in. And sometimes for those people early in the disease that are wearing on the inside, if the shoe, we send them to a shoe place and they put a little wedge on the outside of their heel, that kicks their knee a little bit, not quite to the stage that you saw when we cutting out wedges and fixing bones, but it does the same thing. So in somebody that's wearing on the inside, putting a little heel wedge on the outside of their heel can make them feel better and sometimes postpone. That's another good conservative way to avoid surgery.
Okay. If your MRIs and all of your results show 2 knees bone on bone, 2 knees meniscus tears, is it like just go for the total replacement or see if you can have partial knee resurfacing on both?
Well, you know, that's an excellent question because what we see all the time is somebody who has a meniscus or a cartilage tear and has some wear. And what happens there is you're wearing on the inside, and part of that wear is you tear the cartilage. And if you catch it soon enough, you can do the scope surgery and do okay. But some of those people don't do okay and progress very rapidly to needing a joint replacement. And then the question is, your question is, the best way to tell that is, again, you'd have to see your particular instance and look at your particular MRI, and if it was only worn on the inside where the cartilage tear, then the partial replacement may be a good thing to do in you. But that somebody that's had an MRI, that helps us tell where there's other disease, because we don't, you know, we look when we get in there, but it sure is nice to kind of plan and know what we're going to get before we cut it open and start looking around.
Hello. I wanted to know what are some of the side effects of having a partial. I had a girlfriend that had one done. She used to be my my workout partner, and she used to do cross-country running about 10 years ago. We used to walk anywhere from 3 to 4 miles a day before she had the knee replaced. I mean, the partial. And then after that was done, we very rarely ever worked out again. So I kind of lost a workout partner. So is there any, sometimes do your body reject it, or just what are some of the side effects?
Well, again, I think I touched on a little about what you said, and that comes with our whole generation is the 55 to even to 70-year-old people. I mean, think about when we were young, nobody would be caught dead in a gym lifting weights once they left college. And now you go in any gym and you'll see 50, 60, maybe some 70-year-old people in there working out. We didn't used to do that. And by the same token, back then, if somebody was just having trouble going to the grocery store and we got them to be able to go to the grocery store and not hurt, they were pretty satisfied. To get the kind of result from any joint replacement that you're talking about requires a near perfect result. Now, when I tell you 9 out of 10 people have good results, I'm not saying 9 out of 10 people have perfect results. And so the partials, a good partial will certainly give you a better chance of doing what you're talking about, but no guarantees. And we don't, you know, as I said before, as you get older, that running is, as long, I still run. I ran this morning, but I don't need one of these operations, thank goodness. But I don't, but if I had one, I wouldn't try to run. But I might go out and walk, I might ride my bike, I might get on an elliptical. I'd still try to stay somewhat fit, but do it in a lower impact fashion. So, you know, and I'll tell you that the newer designs on these are better. I can remember, I'll never forget this gal. I did a partial knee replacement. She worked in a Publix deli, and I did a partial knee replacement. This was 10 years ago. I mean, this thing came loose within a year. And I think it was just, and I had to change her to a total knee. And that's why I said that generation back there, there's a bunch of orthopedists just threw in the towel, said this isn't worth it. If you had too many of those, you're not having a lot of happy campers talking around town what a great doctor you are. So now, you know, with these newer designs, we're getting more confidence back to go back to doing these again, and you stand a better chance of returning. But, you know, that's a lot to ask, and everybody's a little different.
If there are no more questions, thank you, Dr. Lucy. And we appreciate you all coming today. Dr. Lucy will be here if you'd like to speak with him afterwards as well. And you have some information on your desk. Please take a look at it. And there are two that we'd love for you to fill out if you would like. One also has boxes on it for additional information from Baptist Health. And the second one is the one from WJCT, so we can keep these programs coming and make them better and better. So thank you very much.
Right. And our Mako gentlemen over here know a tremendous amount about this. I'll stick around. They have a model up here if you want to look and touch one. You're more than welcome to do that on your way out. Thank you.